and background?
So let's see. I'm out 15 years since training now. My background is I'm a vascular interventional radiologist. I was trained by Suresh Vedantam, who's probably one of the premier researchers in DVT post thrombotic syndrome in the United States now. He's at WashU in St. Louis. So all through my training, it was very heavy um, patient population for DVT and for post thrombotic syndrome. He was a quaternary referral basically for the middle of the United States of America, and that was when we started the ATTRACT trial when I was in training actually back in 2009. So it was kind of interesting to learn from him and see some of these terrible cases because he really got sort of the worst of the worst. When I graduated, I started at the hospital I'm still at today. I'm in Western Pennsylvania. I'm about 40 miles north of Pittsburgh, Pennsylvania, which is the closest city. And we've been pretty heavily treating DVT, PE, all forms of what's called venothromboembolic disease, VTE, and post thrombotic syndrome since I got here back in 2010. So it's been a pretty extensive part of our practice. It's a rewarding thing to be able to offer to people, especially with people with post thrombotic syndrome, some benefit that can very significantly change their quality of life for the better.
Right.
What else can I tell you about? Last 5 years or so, I've been very heavily involved in the percutaneous AV fistula arena, and I have grants from Beckman Dickinson actually in that. I teach doctors how to do that. So that's been a really big part of my practice. Is I've been doing that. We've published on that. I'm at a rural community hospital, so it's a little bit odd that because I'm not an academic doctor, but I've sort of become an academic doctor. I don't know how that worked, but it's been interesting. It's been a fun ride the last 5 years.
Right. Thank you. So, in your routine practice, which part of the venous system do most commonly treat, like a iliofemoral, iliocaval?
So our venous practice includes superficial venous disease. We do a lot of laser ablation, radiofrequency ablation of saphenous veins. So we do that whole spectrum. Our practice over the years. Now there's three of my partners, and I think most of us have gone to treat common femoral iliac disease and or cava disease. That's a little bit less statistically prevalent than the iliofemoral disease. But at least the initial data studies that are out there have demonstrated that treating below the knee, we at least at this time have no significant benefit in terms of decreasing the risk of post-thrombotic syndrome. So unless it's disease that progresses when we see somebody back in clinic in 2 or 3 weeks on anticoagulation, and sometimes that happens. Sometimes they're put on blood thinners and the disease gets worse over 2 or 3 weeks, and we see them back. Then we will go in and be more aggressive with it. But typically, it's from the knee up we will
Mhm.
treat.
Okay. And what's the ratio between like a lytics versus mechanical thrombectomy?
Oh gosh, I bet between over the last probably 7 or 8 years, I think the amount of TPA that we use for acute DVT has probably gone down 60 or 70%, I would
Mhm.
say. Now, there's still these cases where people come in and everything is clotted. The cave is clotted, both legs are clotted, and they're just a mess. And you know that you're really not going to be able to make sense of anything until you run TPA for a day and dissolve as much of the acute stuff as you can. Those still come along every once in a while, but in our practice, again, it's a 300-bed community hospital. We might see one of those a year.
Mhm.
So I would say we're at probably a 70 or 80% rate with myself and my partners from what I see they do of a mechanical approach to thrombectomy at this point. And that's gone through
Okay.
evolutions as well in terms of devices that we use, devices we have on the shelf. So I think people are starting to our own practice went through a time where we did TPA, and then we had the trellis device, and that was gone. The Helix device was an old one that Medtronic had, and then they shelved that. And then there was the trellis. What was the other one? We still use the cleaner every once in a while, the cleaner 15. I'll pull that out sometimes, but I would say right now we've moved almost 100% to the Penumbra system and away from the Inari system. So most of us, I think, have moved primarily to that. It's just, I think it's an ease of use thing, and it's I don't know, with my partners, there's actually some data out there that suggests that the outcomes on the Inari on the clutch reaver aren't even remotely comparable to just thrombolysis. That people think maybe there's so much damage done that the recurrent DVT rates in that patient population are very high. So there was one published abstract maybe 2 years ago at SIR, and they had a recurrent DVT rate of like 57% at 2 weeks, I think, after. And there was a recurrent DVT rate on just thrombolysis, 17%, I think was the number. And that was published from a guy in Florida. And he promised me and a whole bunch of other people that he was going to publish, get it published and do more research, but it never came to fruition. And I heard that they were very angry with him. So I don't know what happened with that.
All right. So do you use like a penumbra for both like acute and chronic, or just acute?
Yeah, so that's a really good question. This whole like, do you know what you're getting into before you actually get in there? Thing is, it's difficult. The majority of the time, personally, I've been doing this for 17, 18 years. I just assume that I don't know what it is when I go in, because even when you get this clear-cut clinical history sometimes of the patient that had a long recent travel somewhere in mobility, you think, okay, this is just going to be straightforward acute. It's going to be very easy to remove. You get in there and you realize that there was something old that happened a long time ago, and it seems like more times than not, maybe 90% of the time, it's acute on chronic or acute on subacute. So right now, I think what we'll do is we'll just go in with a penumbra and very aggressively use the catheter to scrape the more chronic or subacute material off the wall. And then if it's much more chronic, sometimes you have to go in and do some balloon maceration and whatnot, and really try to break up as much of the webbing material, this sort of scar tissue. I like to call it pulled pork, because that's about the consistency of it. It ends up adhering to the walls, and you just gradually work at it, scrape it off, work at it, scrape it off. But that leads to the penumbra's own problems, or you have to keep taking the damn catheter out to clean it out. So even though they talk about this computer assisted technology right now, where the computer knows how much aspiration to put on the catheter in order to keep the clot moving, the reality of it is the catheter clogs up many times, and you take it out and you have to clean it out. I just did a DVT case from the IJ with a penumbra, a very weird situation, but I probably had to take that catheter out 8 or 9 times and clean it out. So it probably made the procedure an hour and a half longer than otherwise I would have liked it to have made it. But that's kind of how you have to work with that system right now.
So do you scrape it with the penumbra? Or
so the adherent material, we try to, you can scrape it with the penumbra, the tip of the penumbra catheter. If you twist it, it has an angle on it, and you're able to usually kind of scrape the wall and try to get some of that material loose. If you're not able to get it loose, then you can balloon and push the material out to the wall, and it seems like that creates some kind of a ledge or a web, where when the catheter goes back in and you twist at that level, you're able to dislodge that material from the wall and then sort of aspirate it out and pull it back.
And you don't use like a cloud retriever, like a and also like a Renacor, Venacor, those type of devices, like for chronic situation.
Yeah, I mean, I have experience with a lot of those devices. The the claw retrievers, it's a very unique design. One of the problems that you run into is you can't use it when there's a filter in place, an IBC filter in place.
Mhm.
And many people show up with filters already in place that may or may not have clot in them and clot below them. That windsock is so long, it's 35 centimeters long. So you have to actually deploy it up through the right side of the heart and have the coring element down at the level of the liver when you start making an IBC pass or a pass through the iliac veins. So it's if you need to do that and you want to do that, then you have to get a second access in the internal jugular vein with a large sheath to cover the other end of the windsock when it gets deployed. So it gets very cumbersome
Mhm.
to do that. And I think that's why most of us have shied away from it because it's more. I think you probably hear people talking about frog legging a patient. So that's where you end up. You start with them prone; they're laying on their stomach, and then you have access inside the back of the knee, um, and you're coming up to clean the clot out with them laying on their belly. Well, in order to do that, then you have to take the patient, turn them over on their back, and then keep everything behind the knee sterile, then continue to work from behind the knee while at the same time getting access in the neck. And then you need two operators then to work at opposite
Mhm.
ends of the patient. And it becomes very cumbersome and difficult. People in an academic environment, it's probably a little bit easier because they have fellows and residents there to help them. But most of the time in a community environment with most users, it's the doctor and usually a nurse and a technologist that have no clue what you're doing and are very green and very underpaid and very unmotivated to learn and help you do what you need to do for the patients. Um, it's it's much more user friendly to have one access where you can isolate the thrombus and only have that one problem.
Okay. And let
Have
me, sure.
your protection and your access in the same place.
Yeah, that would yeah. Yeah,
And
that's always been kind of like the my dream of using our device is that I can do everything from one access point. I don't have to
okay.
have two access points or sometimes three access points.
Mhm.
And it gets cumbersome.
Okay. And I think that's a concept of the retriever medical devices. Can I get your thought about the devices?
Which device?
Retriever medical
So
partner. Yeah.
our device, I think our device is sort of uniquely designed and in such a way to we know that most acute clot is just wet jelly stuff, and all you have to do is aspirate it, and it'll gradually pull out the clot and push the serum and the plasma out of the clot. So when you pull it out, the clot burden is actually much smaller than it looked when it was on the inside because it's sort of been wrung out. It's had the serum, the water part of the clot pulled out of it. So we know that most catheters are, any large bore catheter can handle this acute stuff. It really then is to the next step where we talk about, especially with DVT, where most of the time when we get in there, it's not acute. It's some acute, and then there's all this other stuff going on. And the chronicity of that material, depending on how long it's been in there, if it's been in there for a month, then we get biochemical cross-linking, and the biochemical cross-linking turns the material mechanically from a jelly into a meatloaf or a pulled pork consistency. And that's where, for me, the device shines because you can focus on one particular stubborn area and isolate it and break it off, catch it and get it into smaller pieces if you need to, but certainly then be able to pull it out. And that's, why retriever came about, was you're actually able to sort of retrieve this thing and pull it out. But by engaging the material mechanically and removing the material mechanically, you don't have to apply such an aggressive approach as sort of like the clot retriever, where they're basically stripping the entire endothelium of the vein along with old material and valves and everything else. Where ours is these, I like to think of them as stent retrievers. There's two stent retrievers on our device, and those stent retrievers give you control over the segment that you want to work on and remove, because these more chronic or subacute clots tend to be isolated to 3, 4, 5 centimeters, where user, once you've cleaned out the acute clot, you can look back and do a good venogram and realize, oh, there's the problem still. I need to go back in there and work on that a little bit more and clean it out. And you can actually isolate that bit and move it out. And you're not destroying the entire vein at the same time. You're just working on segment as need be.
And do you think the device can works well for the acute, let's say, like compared to penumbra?
Oh yeah, it'll work at least equivalent, if not better, just based on the fact that sometimes I think the computer that they have makes things more complicated. There's all kinds of it's visually is very wonderful for people because it has all these lights and it beeps and clicks and does all these sort of things. But at the end of the day, we're still talking about a catheter that, when it has a certain amount of thrombus burden inside, it's not going to be able to pull anything anymore, because once this thrombus gets into the catheter, it negates the negative pressure placed on the other end of the catheter to be able to pull that material out. So if you talk to any engineer about the transfer of and the negative pressure and the force from one end of the catheter to the other, you realize that once you get a good clot burden inside this large bore catheter, the negative pressure on the side you're trying to pull that clot out is no longer applied to the other end of the catheter. So once that catheter gets clogged up, I mean, you can do whatever you want to try to get more material out. It's not going to come out till you clean the catheter out, get it back in there and get to the next segment of clot. And every system that's out there is going to have that sort of issue.
Okay. And do you think the device can so you say like a device can work for both like acute, and chronic as well. And do you think that's, treating those clot type with the single device can reduce your procedure time?
Yes, definitely. There's no question about it. And
Okay.
I think it would significantly reduce the procedure time with anything else that's out there. I've used another device called the venous pounce. And I think there's a few others, and it's the same thing with every one of these devices, where the catheter gets occluded, and in the venous pounce, it's the basket that they have with the Archimedes screw that spins, and it bites into the clot, but it gets clogged up like every one of these other things. None of these devices that are available has a good mechanical component like the retriever, where, like, imagine that the penumbra is in there and it's clogged up. Well, you can't clear it. Whereas with the retriever device, you get yours in there. Let's say it gets clogged up with something. Well, you already have the mechanical component in there. You're just gonna dislodge it and pull the material out with the mechanical component. And you could leave the aspiration catheter in there if you wanted. And then you don't have to keep clearing everything out. You can just pull the material out. You can grab it and pull it out. And really, it would take it from a one catheter, one entry session to or from a one catheter, with the Inari system, you're looking at probably 7 to 10 passes per patient. With the penumbra, it's probably about the same in terms of the number of times that you have to clean it out in somebody that has pretty significant DVT. With the retriever, in my mind, I envision like one catheter. You don't have to take the catheter out. You use the mechanical component to clear the catheter and pull the material out and retrieve it. And it's very easy to get those chunks off the stent retriever portion, the sphere. Based on our lab data and the stuff we did with the pigs, I mean, it worked really well.
And do you put the IVC filter when you're doing the case of like an iliac cable?
Yeah, I almost always use an IBC filter, and there's a lot of disagreement in the community about whether or not that's necessary. And the reason is sometimes you just don't know if there's a big clot on the other side you're working on because you can't see the iliac on the other side with ultrasound. And maybe once a year, I see a patient die. And we call these widow makers when these clots get really big like this. And to that end, my partner just had a patient last week. He was doing a PE thrombectomy on, did not have an IVC filter in, had extensive clot down the other leg. And while he was removing clot, we think the patient had another giant pulmonary embolism and died, immediately died. And that's why for us, at least the way we practice and in our mindset, it's always better to be a little bit safer. The filter devices themselves aren't that expensive nowadays. I think
Okay.
the average price of those is somewhere between maybe 800 and 1100. So in the large spectrum of things with patients, most of us opt to put the filter in. But there's definitely
Okay.
disagreement in communities about whether or not that's necessary.
Okay. So when you put the filter, you have to do the access from the diagramming.
No, nowadays most of the filter devices have longer delivery systems. They all started out very short, and they've all gotten smart and realized that there's a lot more people doing popliteal vein access, and you can just deploy it from the popliteal vein.
Okay. And the retriever has the distal middle sphere, right, for the embryo protection. Do you think that's a variable for like a cable cases?
Yeah, that's I really like that because you can really kind of like break up whatever you want to break up with that proximal sphere, and you can leave that up and just drag that material back and then go back and get more. And that to me is a really nice component.
Yeah.
That's going to be something that's helpful. And I know the IP lends itself to upsizing it because we've had envisioned larger spheres, in the past for different areas mechanically, and it's all possible. We've talked about how to do it. It's I think the IP is really cool because it gives you a lot of different
Yeah.
angles to take on different devices.
Okay. And the proximal middle sphere can be movable like a 5 centimeter. Do you think this length is good enough for like a idiofemoral and a idiocable?
Yeah, yeah. I mean, I think the five's probably reasonable. I guess, you could say a little bit longer, but I know like when you're moving the 5 centimeters, it feels comfortable. So, if it goes longer, then it's certainly going to change the ergonomics of the handle, and how the user is able to grab it and use it. And somebody with smaller hands, the throw is going to be a lot, weirder for them, more difficult. Somebody with a larger hand, another 3, 4, 5 centimeters might not be a problem, but it seems like it feels good when you're using it now. So, could it be adjusted? I would think the engineers would be able to do that.
All right. Thanks. Any question from Terumo side?
No, makes sense.
No?
Yeah,
All
that's really
right.
helpful.
Yeah, this has been really helpful, Dr. Brown. Thank you so much for your insight.
Yeah, sure.
Yeah.
Yeah, do you have any questions for us?
Gosh, I don't have any questions. Yeah, I got lots of questions. Like,
You got 2 minutes of questions?
yeah, my question is like, yeah, let's get going. I just wanna like attack DVT and PE. And I think we have the best solution. I think this solution is unlike anything else. And I think the fact that we have the IP that goes back to 2015 or whatever we have, and we've got a lot of IP built on that and a lot of good engineering that's been done. I wish I always tell Ben I wish I had it on the shelf now. I'd pull it for every case because I already know kind of what it is, what it can do, and how it works.
One last question. If this comes in the market, let's say like what person do you're gonna use its devices? You're gonna use it for all cases? Like is that like a
If we're able to, if we would start with the DVT, I think I could easily, I know I would use it, and I could probably easily convince my partners to use it. And I don't think there's any doubt about that at all. And then once we get the 24 French, if we get that too, I know that's going to pull out clot out of the lungs better than an ARI. I think once we start down that path of sales and marketing, I don't think it's going to be very difficult to switch users over. I just don't, it's the same problems with these patients that you run into with large bore aspiration and the mechanical devices that are currently available. When you talk to doctors, depending on what they're trained, independent of what their training is, their background, you always hear the same complaints, the same kind of, what do I do when it doesn't come out? Like, why can't I grab it? Why can't I do more with the clot? And it's very, very similar, the number of complaints. And I think, Ben has shared with you, the one thing we know about DVT and post-thrombotic syndrome is that the more clot you get out, the better the patient does in the long run. We don't know like what the optimal is. We know there's a direct correlation between how their risk is for post-thrombotic syndrome and how much clot is left behind. We don't know exactly what it is or what kind of clot, but we do know that there's a significant correlation. So I think for most users out there, when you offer a product that's going to be able to change that paradigm for them and take it from leaving 60, 70% open and leaving a little clot behind and offering them a device that can, get it to 80, 90% clear, they're going to choose that just based on the data that says that their patients are going to do better in the long run.
okay? Do you think people are comfortable, switching from like a penumbra to a retriever for acute cases?
Yeah, I think that's the easiest one right there. I know Penumbra is exploding in terms of their sales for DVT, but their catheter clogs up just like them all, and having something mechanical that could clear out your catheter, is key. That's the biggest thing.
All right. Yep.
Hey, Yuji,
Yep.
if I could let you know, I'm going to be sending you a presentation after this call related to post-thrombotic syndrome, PTS, and a lot of the data around what Dr. Repko just mentioned. So I think it's about a 10-slide deck, but it's really informative, just taking the data that talks about more clot removed, the less the incidence of PTS. And PTS, as I've been researching, is a really ugly after effect of DVT. It's really life altering. So I'll share that with you when we're done here.
Yep. That'd
Awesome.
be great.
All
Right.
Thanks, man.
Again, thanks so much for Victor Brennan.
Yeah.
This
Have
is
a
very
great day,
helpful.
guys.
Thank you.
Yep.
Yes.
Nice to meet you all.
Thanks, man.
Have a good day. Bye-bye.
Yeah.